Good morning. I'd like to call to order the meeting of the Health Services Committee of the UC Board of Regents. I'd like to welcome everybody and thank you for your interest in the University of California and for taking time to be with us today. The Regents very much appreciate observations and opinions provided, and it's important to hear from the public in considering issues of importance to the university. With that, I'd like to move to the first item on the agenda, which is public comment, and I'd like to recognize the Secretary to review the procedures.
Thank you. This morning we have 13 individuals who would like to address the board, and each individual speaker will have up to 2 minutes to address the Regents today. Once I call your name, you will receive a call shortly, or if you're here in person, please make your way to the microphone in front of the audience seating. At the end of your time, you will hear the timer. Please be mindful of those speakers who will follow you and quickly finish your thought once your time has elapsed. To hear from as many speakers as possible, the Regents do not use these public comment periods for an exchange with speakers. Regents' questions resulting from your comments will be referred to the appropriate staff. The Regents also appreciate written comment, and you may submit your comments or other correspondence by email to the Regents' office at any time. A reminder for those of you participating by phone that once it's your turn to speak, please mute any device you might be using to listen to the meeting. If you're here in person, please wait for my colleagues in the tech booth to call your name and then make your way to the microphone in the front. Our first 5 speakers today are Georgia Lavery Van Paris, Julianne Lempert, Sarah Gibson, Feliza Valid, and David Warren.
Georgia, please proceed with your comment.
Good morning, Regents. I am a 4th-year public affairs major at UCLA and co-founder of Ignite at UCLA, a reproductive justice advocacy organization on campus. I'd like to give a quick trigger warning as I will be discussing rape and sexual assault as it relates to student rape test kit access. I am here today to ask if the UC Regents Health Services Committee will consider expanding student rape test kit accessibility. Rape test kits include essential DNA evidence to help identify and investigate perpetrators of rape, making them the most important and often only piece of evidence in rape investigations. As someone deeply involved in survivor justice issues on campus, I know firsthand that UC campuses have many barriers to accessing rape test kits, the biggest one being transportation. UC students travel 17.92 miles on average in the immediate aftermath of sexual assault to get a rape test kit. This can be as high as 44 miles in rural areas. Students can be put in positions where they have to choose between calling the police, paying for an expensive Uber to the nearest rape treatment center, or not getting a rape test kit at all. This is an equity issue, as in studies cited by the ACLU, low-income students and marginalized groups are already less likely to report sexual assault, start an investigation, or even be believed. Rape test kits must be easily accessible to survivors on all UC campuses, and we want to work together with you to address this issue. Thank you.
Julianne, please proceed with your comment.
Good morning, Regents. My name is Julianne Lempert, a political science major and the legislative co-chair of Ignite at UCLA. I'd like to reassert the sexual assault trigger warning. The nearest designated rape treatment center for UC Merced students is the Family Healing Center in Fresno, which is 63 miles away from the dorms. The closest general hospital that provides sexual assault forensics exams is Memorial Hospital Los Banos, which is 44 miles away. The issue of accessibility does not stop at unreasonable distances, but also a lack of administrative communication. Neither of these resources are listed on the medical care page of the UC Merced website. Only the Valley Crisis Center's hotline, the center that does not provide the actual exams. We must list the proper center locations on these web pages. Students should not have to read the fine print, scroll endlessly, or be transferred from operator to operator in order to find the care they need. The correct and direct phone numbers must be placed at the top of UC school websites to ensure the smoothest coordination of care. Thank you.
Sarah, please proceed with your comment.
Good morning, Regents. My name is Sarah Gibson, and I'm a 4th-year public affairs major at UCLA and president of Ignite at UCLA, a reproductive justice advocacy organization. I'd like to reassert the trigger warning once again. UC student survivors currently face significant barriers when accessing necessary resources in the aftermath of a sexual assault. Let's look at UCLA, for example. During every single freshman or transfer orientation, UCLA informs students to call the Rape Crisis Center phone number listed on the back of their Bruin cards in the aftermath of a sexual assault. However, just one phone call to the line reveals that it leads students to UCLA's Santa Monica General Hospital phone line rather than the state-of-the-art Santa Monica Rape Treatment Center. In fact, a nurse from the center said the number listed on the Bruin card changed nearly 10 years ago. Administrators within the UCLA Title IX office, CARE office, and ASH Center all recognize this dire problem, but have taken no urgent nor official action to make a seemingly quick change for all future Bruin cards. Students should not have to jump through hoops to find adequate support for an extremely traumatic experience. Today, I am here to ask the UC Regents Health Services Committee to commit to holding UC schools accountable for protecting students' reproductive, physical, and mental health. Thank you.
Please forgive me if I mispronounce Filza or Feliza. Please proceed with your comment.
Good morning, Regents. My name is Filza. I'm the legislative co-chair of Ignite at UCLA, a women's advocacy organization. I'd like to reassault the sexual assault trigger warning as I continue to discuss such topics. We decided to make direct calls to UC campuses to request information on local resources given to their respective students. At UC Berkeley, we were transferred 6 times by local operators before being given the right contact information. At UC San Diego, the Rape Crisis Center hotline did not pick up the first 2 times we called. At UC Santa Cruz, the CARE office transferred us to a resource that sent us straight to voicemail. This pattern continued to plague our research amongst the other UC schools. If we are confused now, imagine the panic in the aftermath of an assault. If we are irritated now, imagine the exasperation in the aftermath of an assault. If we are tired now, imagine the exhaustion in the aftermath of an assault. Will you commit to helping us promote survivor justice so that survivors do not feel alone in the aftermath of an assault?
David, please proceed with your comment.
Good morning. My name is David Warren, and all of these young people are making me feel really old as an octogenarian. I went to UCLA before there was a 405 freeway. I'm called in today. I've sent a letter. I hope you'll take the time to read it, because emergency medical services all through the state are near a state of collapse. Because we're octogenarians, my wife and I have to use UC Davis Medical Center, and God willing, Mr. Speaker, my wife will see you at the legislative seder, although I don't think that's going to happen. Something needs to be done to help meet the demand. There shouldn't be people laying on the floor screaming in pain. There shouldn't be senior citizens waiting in the emergency room for treatment. My wife should not have to wait 5 to 8 hours just to have her blood pressure checked. When she arrives, her blood pressure systolic is over 200. It's not the staff that is the problem. It's the demand that's a problem. The UC system is now the physician of last resort for too many people. The buildings are overused. Light bulbs are not working, just in the elevators as a classic example. All the university campuses have places for outpatient treatment, and outpatient dock-in-the-box facilities should be manned by the hospitals in order to divert non-emergency care to the dock-in-the-box treatment. I ask that, unlike these other young people, that we address the issues of the mentally ill, the senior citizens, and the substance abused who need medical care in the emergency room to have access by diverting those people who have common colds into medical outpatient facilities on university campuses. I hope you will address this to the legislature, along with the need for student support. Thank you very much for your time. Have a good afternoon.
Our final speakers are Tricia Bennett, Kalia Williams, Tasha Braden, Candace Zomalt, Stephanie Watts, Jason Perez, Gabrielle Mughadam, and Cynthia Garcia.
Tasha, please proceed with your comment.
Hi, good morning, everyone. My name is Tasha Braden, and I have been employed with UCLA for 4 years in the Financial Clearance Unit and a member of the Teamsters Local 2010. Since beginning our remote work from home, we've endured excessive micromanagement, personally from my direct supervisor, which affects patient care directly as I spend more time explaining why or the duration of time I'm in an account than actually clearing a patient's account or appointment. This affects me, my morale. It affects my anxiety level, stress level, which I am now taking medication for. Just asking that we support the Office of President Investigation and hold management accountable to the workers and to patient care. And that's the gist of what I have to say in regards to what's happening in the Financial Clearance Unit. And I just want to say thank you for your time and listening to me.
Candace, please proceed with your comment.
Hi, my name is Candace Zoma. I also work in the Financial Clearance Department under my supervisor, who is pretty new to the group. Her name is Jennifer Armstrong. I'm just experienced a stressful environment when I go to her for assistance more than 3 times, and I haven't received any assistance. She more so wants to explain to me why am I just reaching out to her. I should be reaching out within 10 to 15 minutes. However, I am on the PAT liaison team, so I have to retrieve information, verify it, enter it, get the authorizations, and much more. My manager finally explained to her that the PAT team does not have to reach out to her within 10 to 15 minutes on each account if needed. And, I mean, after explaining that numerous times and it falling on deaf ears, it's pretty stressful. It is affecting my morale as well. I've been here for 8 years when I don't know, it's just been a lot of anxiety since she's come aboard. However, I do want to say Eddie is doing a great job with supporting me thus far. But that's about it. Thank you so much for your time and have a great day.
Stephanie, please proceed with your comment.
Good morning. Hello, my name is Stephanie Watts, and I am a union representative with Teamsters Local 2010, representing over 1,000 members working for UCLA Health. My comments today are specific to the 369 members I represent in the Financial Clearance Unit under the direction of Teresa Kiles. As a former employee in this department, I am a witness to the unhealthy and hostile work environment this director has created and encourages. Leadership hides behind unreasonable work rules to justify their micromanaging. The dedicated workers in this department are committed to patient care, and they take pride in working for UCLA Health. Sadly, while serving the patients and communities, these workers are now experiencing mental health issues from the managerial style Director Teresa Kiles proudly touts, and they are now the patients needing care. UCOP Labor Relations received a group grievance with over 200 signatures over 2 months ago, and although UCOP agreed they would investigate, to date, the investigator, Marie Ann Hairston, has not contacted anyone at the Financial Clearance Unit or the union regarding this investigation. I am here today to ask the committee to take a close, honest look and support UCOP's investigation into the unfair and disrespectful treatment occurring in UCLA Health Financial Clearance Unit under FPG. Thank you for your time and consideration.
Jason, please proceed with your comment.
Hi, my name is Jason Perez. I've been a Teamster Stewart with Union 2010. I work for UCLA. I've been there for over almost 4 years under the management with Teresa Kiles with the Financial Clearance Unit. When I first started, it was a great department until recently. Management started micromanaging, making it unhealthy for us to work. Getting calls from our desk phone, our cell phone, text messages, emails, and messages through the computer to the point to where people like myself are getting sick due to anxiety and undue stress. And when we bring it up to management, we are met with retaliation from management. It's making it unbearable for us to work. All we ask is that you support UCOP in the investigation and make sure that UCLA Financial Clearance Unit management is held accountable for this. Thank you.
Gabriel, please proceed with your comment.
Good morning. My name is Gabriel Mogadam. I work for the FC unit for UCLA Health under the direction of Teresa Kiles. I've been with UCLA for 4 years. I know it to be a great organization to work for. However, in the last several months, we in the FCU department have been subjected to arduous, overbearing, and unnecessary micromanagement, which has placed many of my coworkers and myself under tremendous amounts of stress and has prompted many of us to take medical leave due to such stress due to a hostile working environment. There are many instances where micromanaging has been deemed unnecessary and demeaned us by criticizing our work ethic. There have been several instances where we have been accused of not starting our assignment till 30 minutes after our start time. I have shown on many occasions that I have started my assignments immediately after my work, but they continue to make the same charges against me. This has inhibited my ability our ability to provide exceptional patient care. It is my sincere hope that we can address these issues today and that this investigation brings about a resolution that would be beneficial to us all. Thank you very much.
Cynthia, please proceed with your comment.
Hello, my name is Cynthia Garcia. I work at UCLA, the Financial Clearance Unit, under the direction of Teresa Kiles. I have been an employee for almost 4 years, and in that time, my coworkers and I have experienced harassment, retaliation when we speak up, micromanaging, as well as various other forms of bullying. It is very discouraging as an employee doing my job to the best of my ability to be treated this way. As an organization that prides itself on excellent patient care, it's unfortunate that this ideal has fallen low on the list of priorities under this management. Can you imagine showing up to do your jobs and having to work under these conditions? We all need our jobs, but it shouldn't be affecting our health to do them. In my department alone, we have had a change in managers at least 5 times within the past year. As an employee, I understand that management has a job to do as well, but cultivating this toxic work environment isn't making either of our jobs easier. So I urge you today to help us improve our work conditions by supporting the UCOP investigation into the Financial Clearance Unit management. Thank you.
Kalia, please proceed with your comment.
Hi, yes, I represent the UCLA Financial Clearance Department in endocrinology and Teamsters Locale 2010. I have experienced some things, quite a few things that are unfair in the Financial Clearance Department, especially starting with wages. I have over 20 plus years of experience in the healthcare industry working for top world-renowned hospitals. They started me off at base pay, which I think is unfair. I think a person should be paid off of their experience. I'm not sure why they chose to go that route, but I think that needs to be looked into. People need to be paid for their years of experience. Another thing is the management and the supervisors. They're not providing adequate help to us employees. My supervisor, my manager, when you send them emails, no one is responding. You're sitting there waiting for responses. We're not getting the help we need, which results in an unhealthy environment, which puts stress on us. I have called out quite a few, 2 days last year because of the stress of this job. I felt like I was going to pass out because I needed to take some health days off. because it's so much strain with this job, not getting the help that you need, the micromanaging with these supervisors, the way they talk to you. It's like modern day slavery. It's like a whip going across your back. It's like, where's the help that we should be getting, and who's going to help us? Who's with us? Who's standing with us? We need help because this has to change. I'm reaching out to supervisors, no help. And it's like, okay, what's going on?
Thank you all. That concludes our public comment period.
Thank you. Again, we want to thank you all for your comments and for attending the meeting of the Health Services Committee. This concludes our public comment period. We will now hear from President Drake.
Thank you very much, Chair Perez, and to you, Vice Chancellor Mazziotto of UCLA Health, who's helping us to tee up these important discussions today in Dr. Byington's absence. Before we turn to our agenda today, I'd like to make a few brief comments. First, I'd like to commend the important system-wide work on understanding and addressing long COVID. As you know, COVID-19 has been a mass debilitating event and has long-term consequences for many patients, providers, and our health system. There may be as many as 2 million long COVID patients in California alone. With these challenges in mind, UC Health has launched a vital educational program to share with providers the lessons we've learned from academic health professionals across the UC system. This coordinated effort will help more community and primary health providers screen patients for long COVID, manage symptoms, and make specialty referrals when necessary. This is an example of the very best public service that the university provides to our state and beyond, and I'm grateful to everyone at UC Health who's contributed to this important work. I'm also looking forward to the presentation and our discussion about the work of the University of California's Global Health Institute. I have the privilege of having a long history with this institute, working on the steering committee at its inception many years ago. And all these years later, I'm proud to see this effort evolve and grow. The Institute is another excellent example of collaboration across the 10 UC campuses and beyond. Addressing the world's emerging health needs is a noble and fitting challenge for an enterprise as large and diverse as ours. And finally, as we convene this committee meeting for the first time in 2023, it's worth noting that it's been nearly 3 years since the start of the pandemic. And I want to say that once again, actually longer than 3 years if we think of other places in the world. I want to say again how grateful I am for the frontline workers in our academic health centers and recognize our UC Health colleagues for all they have done and all they continue to do every day to care for patients with excellence and compassion. And with that, Chair Perez, I will turn it back over to you.
Thank you, President Drake. Now we'll move on to our first item, item H1, proposed request for approval of Hillcrest Medical Center, San Diego. But before we do, I'd like to recognize Dr. Mazziotto, who will be helping oversee today's meeting. Dr. Mazziotto.
Thank you, Chair Perez. I just would introduce Chancellor Kozlov to welcome our newest member.
Thank you, Dr. Mazziotto, and thank you, Chair Perez, for this opportunity. I want to do two things today. One is say a little bit about the Hillcrest Hospital. At the same time, also say thank you to a person who just left one of our positions and to a person who just replaced that person. So let me start with the Hillcrest Hospital. This hospital serves three very significant goals and purposes for UC San Diego and the community. Number one, it addresses the seismic issues from SB 1923, very significant. Number two, it brings state-of-the-art facilities to Hillcrest, which is at the edge of, if not the underserved population of UC San Diego. This is where most of the underserved population goes, and we're going to bring the state-of-the-art facilities from our La Jolla campus to this location. Again, very important. Number three, it's going to reimagine Hillcrest as a location, and the community is extremely supportive of what it's going to do. Especially, we're going to add like 1,000-unit residential possibility on this campus, and it's going to change the nature of Hillcrest. So that's why I'm really excited about this. It's a $3 billion project, and I can tell you there's a lot of support, and I'm completely supportive of this transformation. Before I give this to Patty, let me say a big thank you to Dr. David Brenner, who served as our Vice Chancellor for 15 years, and under his leadership, our health system, our School of Medicine, the whole health enterprise grew significantly, including building the Jacobs Medical Center. So my thank you, my gratitude, my appreciation to Dr. David Brenner. If you're listening, sir, thank you very much. Next, I want to welcome his replacement, an equally capable person, Dr. John Carruthers, who's sitting to my right, who comes from University of Michigan most recently, but before that, he was at UC San Diego for 13 years. As GI division chief, went to Michigan as chair of medicine, an amazing person, great accomplishments at Michigan, changed the Department of Medicine, a member of the National Academy of Medicine, and I cannot tell you how excited I am for him to come back, as I say, come back home. So Dr. John Carruthers, to you, sir.
Is this on? First, I want to thank my predecessor, David Brenner, for all the work he's done in setting things up. It's a pleasure to be here before the Regents, Chair Perez, President Drake, and this Healthcare Committee. I want to thank Chancellor Costa and Vice Chancellor Mazziota for their wonderful comments. I just want to tell you just briefly about myself. I'm a product of public schools. As Chancellor Costa mentioned, this is my second tour here at UC San Diego, and my first one is where my academic career was built. I bring some experience from Michigan, and I hope that does well for our own campus here. But one of my reasons for returning was for this world-class academics and its healthcare and research capabilities. And just to mention Hillcrest, I practiced at Hillcrest from 1995 to 2009, notwithstanding the earthquake codes. It absolutely needs a refresh from, as per Chancellor Costa mentioned, not only for the care of our patients and for how we train California physicians who will be practicing here for the next 20 to 30 years from now. So thank you for having me. My colleague and UCSD Health CEO will present, Patty Mason will present the vision for Hillcrest to the committee.
Great, thanks, John. Before I get started, I wanted to do two quick introductions of two members of my team, my colleagues. First, Lori Donaldson, who's back. Lori is our Chief Financial Officer. Lori has been at UC San Diego for 32 years and is our most long-standing CFO across UC Health. And Douglas Cates, who is our Chief Strategy Officer. Douglas has been with us 5 years by way of Cleveland Clinic and has been a tremendous asset to our team. So the Hillcrest campus has been an important part of UCSD for almost 60 years. While much has been accomplished with the current campus, much of the infrastructure has outlived its useful life, and there's an opportunity to take care of its wonderful location in the heart of San Diego to better serve the community and advance the mission of the university. This reimagining began with this tremendous partnership between the campus and health coming together to put together a plan that would be revolutionary, that would be transformational for the community of San Diego. Next slide. Do you move the slides, or do I? Nope, they got it. Great. Go one back. Great. So this picture shows the final expression of the long-range development plan in roughly 2036 with all the labeled components along the way. It's a 6-phase project. We're in the beginnings of phase 1, which is the outpatient pavilion you'll see in the orange and the parking structure. So if you come on that campus today, you'll see a tremendous amount of construction going on, building those buildings. They'll be complete in 2025. We wanted to start specifically with the outpatient pavilion so that we could bring cancer services, integrative services, surgery, and other high-end services to this campus, which would both create access for the community and also create a little bit of a financial engine for the replacement. This is a hard project because it involves the replacement of a facility, right? So it doesn't have this natural growth of revenue stream associated with if you were building a new facility. It's a replacement, right? So it's a very difficult project from that perspective. So focusing on the outpatient pavilion really provides a little bit of a financial engine. Once that phase is done, we'll start the first phase of housing, as the Chancellor mentioned. That will produce about 500 units, and then ultimately will be 1,000. That will be available for staff, residents, fellows, community, whoever gets there first, because I think they're going to be in high demand, but really focused first on our internal communities. Then we'll replace the hospital. That's what we're here to talk about today, and then we'll finish the housing post the hospital replacement. As the Chancellor mentioned, the triggering issue is the seismic requirements for the hospital. But as Dr. Crothers mentioned, the infrastructure itself was built in the early 1960s. There are 36 buildings that are post-useful life and need to be replaced. The hospital itself, as the rest of the campus, supports local, diverse, urban community, and almost half of the inpatients at Hillcrest are Medi-Cal. Next slide. So Hillcrest today, as I said, serves a very unique and vital role in the community. It was opened in 1963 as the community hospital, as the county hospital. UCSD assumed management of it in 1966. And then purchased it in 1980 for $17 million at the time, including a commitment to serve indigent patients. It provides critically needed services for the community, including the trauma center, the burn unit, the emergency services, comprehensive stroke, hyperbaric, and our very own Owen Clinic, which started in 1983 and is focused on our HIV population. This hospital today is heavily driven by emergency room visits and medicine issues. Part of and you'll get a sense of how we're going to change that as we reimagine the future. So, next slide. Sorry, do I do it? Thank you. Okay. The vision is really to be an academic medical center for the heart of San Diego, and you can go down and look at these principles, providing a comprehensive environment for faculty, really an anchor for them. A place where they don't have to run back up and forth up and down the freeway, but they can really anchor in Hillcrest and have access to dry labs and administrative space as well as their clinical space. That it has anchor programs that draw across the region, that we expand critical care and interventional platforms, and we create a great training experience and translational research experience for our tripartite mission. I just wanted to read a couple of the principles that we've been using as we've been thinking about the program for the hospital, just to give you a sense of it. I think it gives a good description. First, that Hillcrest will always remain an academic medical center with destination anchor programs. That the health system must be able to generate enough free cash flow to cover the debt service for the project, right? And we'll talk about that in a minute. That Hillcrest will be positioned within UC San Diego Health as an inpatient center of excellence for trauma and indigent care, emergent care for the region, even as the outpatient and other Hillcrest-centric ambulatory investments support elective volume growth, which will be part of the engine that helps us sustain this facility. That it'll be complementary to the outpatient investments that we're making across the region. That the clinical program does not need to have a clinical program doesn't have to have a presence in both campuses, right? It can either be in one or the other, but certain programs will have presence in both of our campuses. And that any redistribution of programs between Hillcrest and La Jolla will be done in a manner that helps advance the tripartite mission. So these are just some of the principles we're using to advance this campus planning. So in terms of the scale of the project, As mentioned, we did a long-range development plan. At that time, we imagined that we would be replacing the hospital up to about 300 beds. Today, the effective occupancy is around 323 beds. It's licensed for more, but many of the beds are not usable today. At the same time, just to give you a perspective of what's happening at our health systems, any given day, including today, we have over 100 patients waiting for beds in our hallways. Our emergency department is our biggest inpatient unit as we sit here. So even before you think about population growth and market share and program growth, we're already behind about 140 beds where we need to be. We're not taking in transfers. We're actually curtailing some surgeries in order to handle the volume through the emergency department. If you walk through our facilities today, we took the medical education theater and ripped out the carpet and put in hospital beds for patients. So we're looking at every nook and cranny. And I just say this to give you a perspective of where we think we need to be in the future relative to beds. So as we move forward and think about the Hillcrest campus, we think that it actually sustains at least a 460-bed population. However, we have some restrictions in being able to achieve that growth. First, when the CEQA process was done, and the envelope was less at the time. So it was, I think, up to around 350 beds. Secondly, there are site restrictions, right? If you look at that first picture, there are a lot of restrictions in terms of what we can do in terms of sizing because of all of the other things going on the campus. And the third is the funding available. This will be, the hospital replacement alone will be probably a $1.8 to $2 billion project, plus capital equipment, which will probably be in the $300 to $400 million range because of the amount of surgeries and procedure spaces we have. It'll be funded with philanthropy and with debt. The debt is really a challenge in trying to find and work with, and there's been tremendous support from President Drake's office and others helping us look at low interest debt to helpfully do some of the funding for this project. And that would be extremely helpful. So those are all the limitations in terms of how we can get to the sizing. So right now, we're planning for 350, 375 beds. If we get to 375 beds, we'll be able to accommodate the growth in neurosurgery, neurosciences, vascular, cancer, women's and infants programs. We will not be able to accommodate growth in general surgery, urology, abdominal transplant, and select GI and GU cancer. Sorry, Dr. Ramamurthy. So we would ideally, want to be able to build bigger. At this time, when we think about bringing it through capital planning, we'll be probably bringing through something between 375 to 400 beds. Again, if we can nail down the funding. The conceptual timeline, we hope to go to get P funding in the fall. We would break ground and have the hospital complete somewhere between the fall of 2031 and 2032. The existing hospital will remain operational the entire time. And I think with that, next slide. There we go. Yep. That's it.
Regent Sherman.
So on the restrictions, as far as the actual physical restrictions, what would be your absolute limit on the number of beds you can get in the hospital? Because it seems to me the non-physical you can overcome in one way or another between now and when you would start. So just based on the topography, et cetera,
460, is that right? You can hit the button.
Speak.
Hit the button.
Okay, there we go. Sorry. We won't know the exact number until we get into the design work. We know what the size of the floor plate can be. The constraints are around height as well and the footprint. We think we can get up to maybe 425 in the long term. just on the basis of the physical constraints, but there are still the CEQA considerations as well in that number.
It would seem to me, I mean, we're always running out of space. You know, I talk to any of the hospital centers, everybody's overcrowded. I would seem to me we should push to the maximum and deal with the administrative, CEQA, et cetera, everything as we go, and see if we can maximize it. Because it sounds like even with the physical restrictions, you still get in the mid-upper 400. So anyway, thanks.
We appreciate that.
Regent Makarician, followed by Chair Lieb.
Thank you. I had the same concern. Actually, Patty, if today 321 of the beds are being used from the 381, I mean, right now the hospital has 381, right? Is that what it's licensed for right now?
It's licensed for 381, but it's not able to be used or I can staff it. It's just the rooms themselves are not really usable anymore because of the age of the facility.
Okay, but so then the CEQA issue is not going to be a big issue, and but you stated that you already have 100 people waiting for beds at any given day. So it seems to me that the same thing that Richard raised, that we should go for a much higher number, because this was a 1963 built hospital, and now look how many more years have gone by, and I think we should go for the maximum, because the height, I don't understand why the height is an issue. It's not in a flight path. So the site restrictions, I understand, even though we haven't looked at the design. The funding, you said the funding is an issue, but if you have people waiting on the hallways, hospitals are always profitable, so it's just a matter of cash flow. So I'm just not comfortable as to why we're going for 350 or maybe maximum 375, where existing hospital is 321 out of the 381 bed. If you're building something, I think considering that this was built in 1963 and today we're in 2023, must be need for a much larger hospital. And if you're taking this on, and I don't think that we will have for the next 10 or 15 years anything else coming in that area. So that's my concern. If you can just maybe explain more as to what the real restrictions are that you're deciding into these numbers.
Yeah, thank you so much, Regent Makarician, and both you and Regent Sherman express a sentiment that's shared very deeply across our institution as well. How we're beginning to think about this is that even net, we're going to need to add more beds in La Jolla as well, which will also be another 10-year project. And then we're actually going to need to find some short-term relief for beds. And so as we're thinking about the whole project, we're beginning to think about how all those pieces might fit together. But I think if you ask, and Dr. Ramamurthy's here, she can share the view of the faculty. I think most people feel that we need to build this as big as we can.
Chair Lieb, then Regent Riley.
Okay.
Sorry, go ahead, Regent Makarician.
Yeah, again, so what was the funding issue?
So again, because most of this is, so this is over 50% Medi-Cal, and this is a replacement facility. Okay. So it's hard to get, so when you're adding $1.8 billion of debt, at current rates, it's the difference, and Lori Donaldson can speak to this if she would, but it could be the difference between needing a contribution margin of $40 million a year versus $100 million a year. Like that debt instrument is super important in order for us to get this project done. Lori, do you have any comments on that?
No, I would just add that, we've been working really closely with, CFO Brostrom's office on some different, funding scenarios available to us. And we're still in, the preliminary programming phases, but what services, how big, what type of margin the project can drive really determines, if we're able to afford it. Are we able to cover, debt service on 1.8 or possibly, higher than that amount of debt?
So would this be, maybe these are more questions that the Finance Committee, but let me ask it so that we can perhaps you can prepare for them if you don't have the answers. But so would this be a standalone? It's not going to be a part of the whole San Diego overall health service?
It's on. We have a single license for both Hillcrest and La Jolla, so it will continue to be on that single license as part of our integrated health system.
I'm talking about financing part of it.
In terms of the obligated group.
Well, you just mentioned that because 30 or 40% of this is going to be Medicare or Medicaid, you may not have as much revenue to support the funding of this. My question is this going to be standalone, requiring standalone financing, or will it be part of the whole thing, which is between the two campuses, you have a lot of funding available to you?
As part of our business planning, we are hoping that by building larger at Hillcrest, that we can then backfill some of our services at our other sites. So when we're looking at affordability, we're looking at the entire system, both campus locations, as far as is there enough incremental revenues to cover debt service.
Okay. All right, thank you.
So let me ask a follow-up question before I go back to Regent Lieb. So Patty, as you're looking at changing the mix of what you do at Hillcrest, and I really appreciate the mission-driven and the tripartite mission-driven approach you're taking and the way you express the principles for Hillcrest in particular, and then how it relates more broadly. But as you look at it evolving over time and growing what's offered there and moving away from being primarily an ER-centric facility, do you anticipate that that changes the payer mix at Hillcrest as well?
I don't think so.
Really? Okay.
I don't think it will.
Very good. Chair Lieb, Regent Riley, Dr. Ramamurthy.
So a couple of things, not to sound like a broken record. Number one, I think you're hearing from the people on this committee that bigger is better at Hillcrest with the number of beds. Whatever we can do in that regard, I think would be really important, just given the fact that the population has grown so much in San Diego County. And I guess that leads to my next point. We are such a vital interest in San Diego County, thanks to the leadership of Chancellor Khosla and yourself and all the others that are working on this project. As a resident of San Diego County, I can, as I've said before, this really is land breaking in terms of what we're doing in San Diego and creating this hospital and what you're doing. And I commend you for really being at the forefront of health concerns in San Diego County. So I really want to thank you for that. I think the community really appreciates what you're doing, and I'm very proud to be on this board where we have someone like yourselves in leadership there really transforming our city. I also want to thank, and I want Dr. Drake to know too, our CFO, Nathan Bostrom, has done a really good job. I've been on several meetings myself with the controller, with the treasurer's office, trying to secure the financing that we need. And Nathan has been really at the forefront of that, and I really appreciate all the work he's doing. Thanks.
He really has.
Regent Riley, then Dr. Ramamurthy and Dr. Drake.
Thank you. So Patty, are you working right now on any possible plans or potential plans or remedies for the 140-bed overflow that you're experiencing every day? Seems like that's not really sustainable for the long term.
I am, and it's covered by an NDA, so I can't talk about it, but hopefully we'll be talking about it soon.
Okay, thank you.
Dr. Ramamurthy.
I wanted to lend my voice and that of the larger faculty of UCSD in support of our Hillcrest plans. This was an incredible effort to include the faculty, both at a macro level, where we had town halls to where we had more, discussions at the departmental level about programs and programmatic growth and what the community needed, all the way down, and I will thank Douglas for this, to the individual faculty and staff level so that we could weigh in on many of the plans for the Hillcrest. And many of us are not just providers in that system, but we live in this community as well. And to echo what Dr. Crothers said, I trained at Hillcrest over 25 years ago. It was old then, so she's definitely due for a makeover. There's no question about it. But this is an iconic facility to all of us in the community in San Diego. It's the place where the community really turns during catastrophes. If you recall, the Cedar Fire of 2003, which was one of the largest fires in the state of California, really Hillcrest facility was all over the news. I remember CNN walking through the halls. This was a huge effort and a lift from the Hillcrest facility for this region of California, and we were all very proud of it. And I just wanted to say that I hope that the regents appreciate what an important facility this is, both to the faculty and to the community. And I wanted to thank Pradeep and Patty for everything that you've done to include the faculty voice in all of this. And we agree it needs to be a bigger facility, but we're sensitive to the issues that are constraining us at the moment.
Are you seeking recognition, Doctor?
Yes.
Go ahead.
Thank you, Regent Perez. I want to make 2 points, particularly coming from relative outside here. First, the Hillcrest campus, which Dr. Ramamurthy and I have worked in for many years, this is really the first design by the University of California. I mean, it was built as a county hospital. So, I mean, so this is really a vision to really make it a true community academic health system. Second, I want to say that what's not recognized in the licensed beds is possible use of short stay beds. Short stay beds don't require, as my understanding, a state license, and we may use those as a way to fill short stay patients, because there's a number of our patients who may not stay more than 24 hours as a way to hospitalize them for a short stay. So those are not in the license number at all.
Thank you. Dr. Drake.
Just a couple of comments. First, I appreciate the presentation. And also to welcome Dr. Crothers back. You took a little detour, and I want to, of course, apologize to anyone who had to be at the school up north, but you've returned looking terrific, and really great to have you back. So welcome officially for that. And I echo what our colleagues have said about the capacity. We know for sure that we'll build it, it'll be done, and the day we open it, it will be full. And so I think that we need to really maximize the space that we have. Many of us have been involved in circumstances like this where we say, let's go ahead and shell some space because we can't finance it or whatever else happens. That's happened here at UCLA and many other places. And you know that when you're done, you're already thinking about how you're going to program that shell space, and wish you'd done it opened it at the very beginning. So I would certainly encourage you to look at maximization. And then it's been about a little over a year since I was at Hillcrest, but just about a year, and I remember having to navigate the hallways to walk between the gurneys that were there because, as you say, the hallways are filled with patients waiting for beds every day of the year. So there's a crying patient need for this. And then something we talk about a lot that I'll mention briefly, but it comes up, we say this 100 times a year, and we have this horrific, sort of unimaginable reminder of the seriousness of it, and that is we talk about the seismic needs of the institution and things we have to do because of our seismic requirements, and we see that just looking at the world that those are really absolute requirements for us, and so I think we need to be moving forward with this project as quickly as we can.
Thanks. If I may just add a couple of things. Similar to the engagement that Dr. Ramamurthy mentioned with respect to the faculty, from the departmental level to the granular level, I appreciate the effort and engagement with the broader community. The engagement with civic leaders, the engagement with philanthropic leaders, the engagement with folks who really turn to Hillcrest for healthcare on a regular basis. And I think that this is really a very good example of what that engagement could look like. And I appreciate all the hard work that went into that, because those are never easy or simple, straightforward conversations. With that, is there a motion?
So moved.
There's motion.
Second.
Motion and second. The secretary will call the roll.
Regents Drake?
Aye.
Drake, aye. Goober? Goober, aye. Lieb?
Aye.
Lieb, aye. Makarasian?
Aye.
Makarasian, aye. Newsom? Park? Perez?
Aye.
Perez, aye. Riley?
Aye.
Riley, aye. Sherman?
Aye.
Sherman, aye. Item H1 is approved.
Thank you very much. We will reset for H2, UC Health Systems Working Group on post-acute COVID. But before we do that, let me go back and ask for a motion to approve the minutes of the December 14th meeting.
So moved.
Second.
It's been moved and seconded. The secretary will call the roll.
Regent Drake?
Aye.
Drake, aye. Goober? Aye. Goober, aye. Lieb?
Aye.
Lieb, aye. Makarasian?
Aye.
Makarasian, aye. Park? Perez?
Aye.
Perez, aye. Riley?
Aye.
Riley, aye. And Sherman? Aye. Sherman, aye. The minutes are approved.
Thanks. Dr. Mazziota, are you ready to proceed with item H2?
Yes, we are. Thank you. Today's topic is in response to a request by the committee to continue conversations about the SARS-CoV-2 pandemic, specifically the long COVID aspects of it, and to bring forward a panel of experts for the committee to engage in a question and answer. I would like to now turn things over to Chief Clinical Strategy Officer Ann Foster for her to introduce the panel and run this part of the meeting.
Just 1 second.
I'll get us wasted. Slides there. Just a little AV interlude here. We'll be ready.
Good morning. Thank you, Dr. Mazziota, and good morning, everyone. So today we return to the topic of long COVID, and we're very pleased to share with you some of the UC Health long COVID activities. We will hear from 2 UC Health experts, and we thank them for stepping away from their clinical duties today. The founder of the UCLA Long COVID Clinic, Dr. Nisha Viswanathan, and Dr. Helen Lavretsky, who is the Director of Integrative Psychiatry in the Post-COVID Clinic at UCLA, and they work very closely together in a joint model. This is a brief presentation on our part, following up from the more clinical presentation we gave you last year that will allow time for your questions regarding our services or long COVID in general and a rich discussion. UC Health has responded to long COVID as it first emerged as a post-COVID chronic illness in a number of ways. UC medical campuses have all formed long COVID clinics and are actively caring for many patients across the state. There are also a number of long COVID research studies across our system, such as the INSPIRE trial, which is led by Dr. Joanne Elmore. EVP Byington formed the UC Health Working Group on Long COVID in 2020, and I've had the great pleasure of convening this group over the past 2 years. We bring together long COVID experts from across the system, representing many medical specialties, along with representation from the California Department of Public Health, and we very much value that public and academic partnership with them. We focus on clinical issues, have helped bring forth a number of educational sessions, and also ponder a number of research issues that is related to long COVID. Most recently, President Drake announced his presidential priorities, which include health-focused priorities such as increasing access to care for long COVID patients, and we've heard this morning that there may be 2 million in the state. Seems there it goes. As part of our educational mission, which we take very seriously, we produced a 12-part long COVID provider training module that you may have already heard about. And it has Spanish and English captions in order to really facilitate greater access to an audience outside the U.S. and to non-English speakers. And it's geared at expanding the knowledge base of providers so we can help increase the number of providers actually willing to screen and treat long COVID patients in the greater community. This is offered free of charge as a UCLA Health continuing medical education course and is also accessible on the UC YouTube channel. We've distributed this series statewide, nationally, met with multiple federal agencies and partners along the way, and also globally, including to 6 million healthcare providers and learners in 70 countries via our partner Project ECHO, as well as to the World Health Organization. I would now like to ask Dr. Nisha Viswanathan to give us an overview of the UCLA Health Long COVID Clinic. Thank you.
Thank you so much, and thank you for the opportunity to talk about our program today. So the UCLA Long COVID program was created here about 18 months ago with the goal of helping our patients who are having persistent symptoms after their COVID infection with two goals. One, to make sure we're making the correct diagnosis, and number two, make sure that we can provide patients care for this complex and emerging medical condition. As you can see here, we have a hub and spoke model, which is we have a core of long COVID primary care doctors who then also utilize our subspecialists, as pictured above, who are able to amplify the care that we provide them. We meet frequently every 2 weeks to discuss our most complex patients so that we can create comprehensive care plans that are more integrated in their model. Overall, the feedback has been incredibly positive. Patients really feel like our practitioners are knowledgeable. We're constantly working on developing our knowledge base, reviewing the latest papers, seeing how we can integrate that into our practice. And I think that is really appreciated by the community of patients that we have created here at UCLA. We also drive a large number of patients from outside the health system as well. The demand has been high as a result. As you can see, referrals received are incredibly high and go in cycles of about 3 months that seem to coincide with when there are COVID infections. And as part of that, we have had to have longer wait times to see physicians as part of this development of the program. About a third of our referrals are from outside the UCLA system and vary from patients within the state to all the way international patients who have come to visit us. The big thing in delivering long COVID care has been the challenges that we are facing. So first off, the time and resources that are involved in caring for patients who have this new emerging medical condition are significant. We are dealing with a younger population who is now dealing with a chronic illness, which is very different from our traditional models of older patients who have chronic illnesses. They may be having issues with brain fog, which make it difficult for them to navigate the healthcare system. They may need assistance with care coordination, more frequent clinical touch points, and may have to deal with issues related to disability that tend to go beyond the scope of the clinic. Because these patients are younger and not traditionally well equipped to dealing with chronic illnesses, they may need more social work involvement as well. And additionally, we're dealing with the struggles of limited information on this actual topic. Every day there are new papers being published, but as we are learning and growing, it is an evolving subject matter. And as part of that, it's been very difficult for the traditional primary care doctor to provide the level of care that has been required in caring for long COVID patients because of the amount of research that is required on their end to stay abreast of all the topics. I will turn this over now to Dr. Lavretsky to talk to us about the neuropsychiatric symptoms.
Thank you. So my role has been to assist my colleagues in primary care with diagnosing and managing neuropsychiatric symptoms of long COVID. As you know, it brought forward mental health problems in the majority of patients with long COVID, but also stress brought in by pandemic and pandemic restriction, resulting in about 50% increase in symptoms and anxiety, depression, and increase in substance abuse, increase in suicides, including in healthcare workers. So the symptoms in those who have long COVID, the symptoms of fatigue, brain fog, chronic malaise, anxiety, and depression exist in the majority of patients. Some have severe symptoms of PTSD, increased suicidality, and a smaller proportion develop psychosis and delirium. And this is an interesting review study of electronic health records of 70 million healthcare records that shows the percentage of those with neuropsychiatric symptoms being about 33% and new onset of symptoms in about 13%. For patients who were hospitalized to ICU, the estimated incidence is almost twice as much, especially with the first diagnosis of mental illness. And this level of neuropsychiatric morbidity is much higher in COVID-19 than in those with influenza or other respiratory tract infections. That shows that COVID virus is a very neurotropic virus. So there are no guidelines for treatment. We're developing knowledge as we go along and learn from each other. The VA healthcare system published this guidelines advising whole person care, basically integrative care, all around wellness, well-being, pressing on physicians to integrate. And I'm an integrative psychiatrist, so I take it very seriously and train physicians I work with to integrate all of that. So in terms of mental health care needs, information services are still inadequate, although general public is learning more about what is involved in long COVID. Access to mental health services that provide counseling and management of neuropsychiatric symptoms of long COVID is inadequate, as the number of trained mental health practitioners who know how to manage long COVID. There's a lack or just very few support groups we refer patients to, usually outside of UCLA, and the lack of sufficient number of neuropsychologists and psychometrists who could assist in assessing cognitive impairment that is imperative for disability claims. And very few available cognitive, physical, and speech rehabilitation services. Disability management teams really lack information and knowledge in handling claims. And that's a big, we spend a lot of our time processing and talking to these disability teams. Thank you.
Thank you both. We appreciate it. And we'd like to open it up for questions and a discussion.
Regent Riley.
Thank you. Thank you for the presentation. I'm just wondering if you see similar long-term effects from other viral infections, and what makes COVID unique?
Would you like to take that?
So yes, we have seen other post-viral conditions. You might hear about post-viral fatigue syndromes. MECFS is one that has been talked about a lot, which is myalgic encephalitis, chronic fatigue syndrome. But long COVID is very distinct in that it seems to have such a variety of symptoms associated with it. And as we're doing more research, we're finding that there seem to be different mechanisms that are at play that can lead to many of the symptoms that are there that have never been previously identified in other post-viral conditions. So it does show while we are using the knowledge base from what we know about other viral conditions, it looks like there is more to be learned that is specific to long COVID.
So I guess I have two questions that go in different directions. So with respect to long COVID itself, what are we learning globally? So I have a neighbor who lives binationally, who just came back from Korea, and who has issues with mobility, use of hands bilaterally, that after every test in the world, they finally have assumed that it's a long COVID issue, but it presents like some other neurodegenerative disease. So what are we learning from other parts of the world? Are these physical conditions like what I just briefly explained, presenting themselves here as well. That's question number one, and then I'll switch directions for question number two.
So yes, I think that the global body of knowledge, I think if there's ever been a time in history to learn from other places, it is now. People are doing a very good job of publishing on the findings that they're having. There's quite a lot of case reports that are helping us inform our knowledge. And absolutely, we do know that one of the symptoms of long COVID is COVID itself can really attack our nerve endings. And this can lead to some individuals who have neuropathy, so they'll have pain or they'll have inappropriate nerve firing that can cause symptoms. But also as part of that, it can actually lead to nerves themselves not working as well as they were previously, which can lead to that weakness.
And I guess in the opposite direction, one of the interests that I had in hearing from this is what we could learn from the limited work that was done around MECFS and how this then could go back and inform our approaches to MECFS. You talked, for example, about the difficulties in dealing with disability and folks understanding disabilities associated with long COVID. I think there's been a longstanding deficiency of folks in the disability area understanding the impacts of MECFS and what can we do to help close the loop there?
In fact, I'm involved in writing of the results of the CDC-funded study that is running through UCLA. Joan Elmore is the PI at UCLA. That the first paper we're writing is on MECSF as it applies to long COVID and learning about corresponding overlapping symptoms. I think both diseases will inform each other about management and the symptom and the progression trajectories. We're not there yet. We spent like 6 months trying to decide what would be MECSF and how to use CDC data, but we're getting there with a lot of help from the CDC researchers. And the MECSF community really decided to progress forward with pushing forward for funding and for research in COVID-19 because of the similarities in symptoms.
Thanks. Regent Lieb, then Regent Resnick.
Thank you very much. This is a really great opportunity to learn about long COVID in terms of the study that you're doing, and you're taking, I want to commend UCLA for really taking a lead in this when I think we talk about 2 million patients so far identified as having long COVID. So this is a great statewide community effort that you're doing, and I want to commend you for that. My question would be more about how do people enroll? My sister-in-law, for example, has long COVID. How do people enroll in this program, and do they have to have insurance? I mean, what if they're Kaiser members or something like that? Who can enroll, and how do you do that?
Yes, so we will see anybody who has commercial insurance at the moment, and the way that it's done is actually through an outside referral process that's sent to our outside referrals department, who then works with the patient's insurance to get authorization for them to allow them to be seen at UCLA. We have been able to see Kaiser patients. I have actually been able to see a few workers' comp patients as well as VA patients. Because of the limited number of long COVID programs around the state, there are not abilities for these programs in every hospital. So insurance programs have been willing to work with us on that regard.
I also consult to other campuses like UCI and UCSD that may not have access to psychiatry.
And what about Medicare patients?
Yes, we do see Medicare.
You will see. So,
and Medicaid.
And may I add also, Regent Lieb, that's the goal of our long COVID training series, is that this is a relatively common condition. 1 in 5 people who've had acute COVID may have long COVID. Those are our best projections, looking at the scientific literature. And it needs to become normalized in a skill set for our primary care physicians across all of our communities. And our goal is really increasing that knowledge base, increasing the provider's self-confidence that they can appropriately screen and begin the treatment or the management of this condition, and then refer perhaps for those more complicated cases to an academic medical center. That's the goal, is that it's now part of our medical ecosystem, and we need to normalize the treatment.
How many people have enrolled so far? Did you say 490?
In your clinic?
Oh, we've had about 1,600 patients.
1,600. And just so people know that are listening, how do you enroll?
So there's two criteria that must be met for initial evaluation. One is that you must have a positive COVID test. So this can be PCR, it can be antigen, but we do need to know that you did in fact have COVID-19. And secondly, that your symptoms must persist for longer than 12 weeks after your initial infection. We know that sometimes with just the acute COVID infection, it can take about 12 weeks to resolve. After that, patients are seen by our long COVID PCPs, and we do a comprehensive evaluation, understanding the timeline of your symptoms, what are the symptoms you're experiencing, and then based on that, we provide an appropriate workup to make sure that we are correctly identifying long COVID. As I initially said, it is a diagnosis of exclusions. We exclude other medical issues that could be at play. So really, it takes a little bit of time after we see patients to say definitively this is long COVID rather than another medical condition. But if our entire workup comes back as negative, then at that point we'll really say this is long COVID, what can we do to manage and treat you?
Thank you.
Regent Resnick.
Thank you, Regent Perez. And thank you for the presentation and the great and important work. I have two questions. One is about long-term, our anticipated long-term healthcare needs and how we're anticipating providing those, and the other is regarding diversity of communities impacted. So to begin with, I'm just curious to know if we're finding that patients that symptoms diminish over time. Are we seeing cure or diminish of symptoms over time? And along with that, what do we anticipate from COVID overall? Are we seeing that it will mutate and that there will be continued infection among communities, and then the implications, of course, would be continued long-term COVID needs, long-term COVID care needs?
Mm-hmm. So I think there's multiple questions there, so I'll try and break that down. So in terms of where we see COVID going and then where do we see long COVID going, in terms of COVID itself, it does seem at present that we are probably dealing with a virus that is going to become a chronic virus that is in our community. Endemic, in that sense, is the word that they use. And what timeline that will present, how severe will the illnesses be in the future, that time will tell. But from what we can anticipate and what we already know about COVID, we do know that we anticipate that as people are continuing to get infected with COVID, especially now a study showing that getting recurrent infections of COVID put you at increased risk of long COVID, we have a high probability that the number of individuals who are struggling with long COVID will actually increase over time. It may not be as exponential as it has been with the initial outbreaks, and especially with vaccinations really decreasing those rates, but we anticipate ongoing needs. In terms of long COVID itself, from what we can see, and from what I have really seen, having done this now for at least 2 years, patients seem to have what we call a relapsing and remitting illness. So sometimes they will get better, and then they may get just a cold, the common cold, and their symptoms will come back. And it gives us suspicion that this may be more of a chronic illness that goes into remission rather than one that is truly cured. And so while we're still doing research on that front to better understand this, many of my patients who have recovered, I have sometimes seen a year later as their symptoms have actually returned. And so what does that mean society level wise for patients, disability? I do think that we may have to reimagine how we deliver healthcare for patients who may recurrently have to deal with a chronic care model, not just an acute illness that is here now and will be gone in 3 months. And so that may require a little bit more investment in social services, being able to, navigate the disability system, and that may require actually, level at the political level, some degree of changes about how we handle disability. How do we view who is disabled and who can be working in the workplace? And so I think there's a lot of unanswered questions at the moment, but you're absolutely right in recognizing that this is probably going to be a long-term issue.
Thank you. I appreciate that. And I just had one additional question, which is regarding impact of communities and diversity. And do we see a difference in impact of different communities, and if we see, and are we within this context, are we serving all of those communities, including low-income communities, for example? So again, multiple questions.
So actually, very interestingly, here at UCLA, we did one of the first studies in long COVID where we actually identified the persistent symptoms that were present after COVID and wanted to see who was actually experiencing long COVID. And interestingly, because we do serve such a broad population here, we had the study in the country with the largest enrollment of patients who identified as Hispanic and Latino. And as part of that, we actually saw that patients across all demographic groups had equal incidence of long COVID, with incidence being greater in women than men, but there was no difference based on ethnic background. That being said, I think when it comes to those who seek care, it is a very different story. And I think this may actually be reflective of, what Dr. Foster mentioned as well, was that we are dealing also with providers in the community correctly recognizing long COVID, maybe appropriately referring patients for care. And really, I think what we have found here at UCLA is that we've had patients who are disproportionately probably higher income and disproportionately white who have sought care for long COVID in our program. And a certain amount of that is what I like to call maybe patients who are more healthcare empowered, who feel comfortable navigating healthcare systems, who feel comfortable reaching out to their insurance companies to ensure the authorizations are going through. And I think this is really pointing to the fact that some of our patient populations may need additional assistance to be able to access care. Once they've been able to access care, I have seen multiple Medicaid patients, but a lot of times they do say that my provider in the community took a very long time to identify what could be going on with me before they gave me a referral to come to UCLA.
Thank you.
Dr. Mazziotto?
Just an observation, I think, as a neurologist, seeing this phenomenon of post-viral infection, multi-organ damage, it's an unfortunate consequence of a viral infection, but it's also a great opportunity in academic setting to understand the interplay between this immune response to a viral protein and the proteins in the nervous system, just speaking about the nervous system. So, I mean, for decades, ME/CFS was a controversial topic. Was it real? Was it not? Was it psychiatric or was it pathophysiological? You know, it's clear now that these things are mediated by this kind of unfortunate similarity between proteins in the nervous system and proteins on a virus. And I think having these clinical trials and exploring these issues in a setting like we have here, and thank you for the work on that, is a great opportunity to get insights into the immune system, the nervous system, and all the other systems that are adversely affected in the wake of these kinds of viral illnesses.
Before I go on to Advisor Marks, just want to follow up on that, Dr. Mazziotto, because I think patients with ME/CFS are still facing those hurdles in many cases. And so the hope is that as we see the large number of folks impacted by long COVID, will change the presumption with respect to the very real challenges that patients with ME/CFS are facing. And then the question becomes, you know, it's one thing for specialists, but how do we engage in a broader educational experience with the broader medical community so that patients that are seeing primary care physicians in the community have a better ability to navigate the care that they deserve, or whether it's ME/CFS or long COVID. And I think that's just something we need to continue to try to wrap our heads around. With that, Advisor Marks.
There we go. Thank you. First, thank you for a wonderful report of the work you're doing and the research you're doing on long COVID and the impact on patients. But I'd like to actually broaden the discussion a little bit because I think it's related to this and focus for a minute on the long-term impacts of COVID on our cities, our society, our children, which will probably take years to sort out and is beyond the scope of this group. But the thing that isn't, it's been my observation in some of the national work I'm doing with academic medical institutions now, as well as what I experienced at my own institution. I think academic medicine, academic health campuses are going through their own kind of institutional long COVID, whether it's the impact on our finances, our capacity, and more importantly, on the health of our workforce. And how are we caring for the caregivers? Even though our physicians, our nurses, all of our essential workers may or may not have actually had COVID or certainly didn't have long COVID, I think we're dealing now at many of our institutions with the consequences of people that have been at the front lines of this, mental health issues, anxiety, resiliency. Are we doing enough internally in our institutions to address their health issues, often mental health issues, that are coming out in all kinds of interesting ways, I think, in our workplaces today? And are we spending as much time thinking about that as we're thinking about our first primary duty to our patients?
Thank you. I think, go ahead, I'm sorry.
Yes, thank you. We're barely dealing with the flow of patients as is. I don't think we're addressing the wellness of our workforce. In fact, the majority of our first patients were our own nurses. And they had severe cases of long COVID leading to disability. And we saw them through 1 to 2 years of treatment. And it was a difficult balance between treating the symptoms, residual symptoms, when they improve but not improve enough to enter workforce back, and how to deal with that. I don't think we were well equipped to deal with it. So many of them became disabled. Many of them were forced to come back to work before they were ready, just because disability ran out.
And I may not have been clear. I was really talking about even people who haven't had COVID, but who are part of our community and are treating patients for COVID.
I think it's a really, really important point, and something we all think a lot about, and trying to think of the right support systems for especially those that were particularly on the front line, but others as well. And one thing that we tried to do in partnership with our chair of medicine was to take our key areas, infectious disease, critical care, ED, hospital, and actually prospectively put them into an opt-out where they would be able to talk with a therapist, and then they could opt out if they don't want to go. Because we were also trying to overcome this stigma around, physicians can't go ask for mental health services. So if you're already scheduled, then you show, right? And if you don't want to go, you don't have to go. And we had about a 40% pickup of people that needed support, and then had some additional support. That's just one. I don't think I think we're still at the tip of the iceberg on this one.
Yeah, I just wanted to address two things. So first of all, similar to what Patty said, we've been really, as we look at our physician and staff surveys, we've been, Vice Chancellor Mazziotto, Dean Dubonnet, and I have also been attending faculty department meetings to really see what else we can do. We do know that a lot of our faculty and staff were impacted by COVID. We're fortunate to have this clinic, and we need to continue to expand it. But we are really trying to stay on top of that, because the wave of that now and the fatigue, there was a lot of energy during COVID, and here in LA we had 4 surges, but now the fatigue of operating at what we're operating today at Ronald Reagan, 118% capacity, 110 in Santa Monica, is adding up. And then secondly, I wanted to make a comment about getting this information out to Medicaid patients. As many of you know, so much of Los Angeles is managed care Medicaid, and so if patients aren't assigned to us, they don't get referred to us. So we're working now with LA Care, which is the largest Medicaid provider in LA. They represent about 2 million lives, to see if we can get carve-outs so that patients can access us, since we're the only provider in the area. So that takes a reach out to the plan, but as you mentioned, Regent Perez, also educating that provider community of the need to refer, and that there is something we can do to help these patients. So thank you both for your commitment to that.
And if I may, I really appreciate the partnership UCLA has established with LA Care. I think it's been meaningful, and I appreciate what you're looking to do there. But the other question, especially at trying to find patients that we don't often touch, is maybe structuring some interactions with the Association of FQHCs.
Oh, yes.
Right?
Yes.
And so going and looking at FQHCs throughout the state and figuring out what we could do there as well.
Yeah, that's a great suggestion, and we just brought in a new CEO for our Venice Family Clinic, which is the UCLA Federally Qualified Health Center. He comes from Marin County and has a lot of ideas of how we can expand more.
Dr. Ramamurthy, did you have something?
You know what? Lily and I must be on the same wavelength here, because it was exactly my comment, but it was about studying the long COVID in healthcare workers, and that really being a big part of some of the issues we're having with our workforce and all the sick calls from our younger generations than we would think. And the consideration that this was possibly a workplace exposure issue and something for us to carve out and think about counseling them and what is the long-term commitment we have to their wellness, and also with a mind's eye towards patient safety, because I think a lot of us just work ourselves to the ground and not really recognizing the impact of a brain fog or a memory issue on patient care, which is a big deal.
Suresh?
Appreciate the fact that we're having this conversation. I would just put in one piece of color, which is into this, is that we haven't mentioned is we have thousands of staff that are on this, that are not just our frontline clinicians. We have food service workers, we have housekeepers, we have patient transport staff, we have social workers, and I think the challenge for us has been calibrating. So at UCSF Health, what we have done in the first half of the fiscal year is try to grant as much leave as we can, bring in as much temporary staff as we can to give people breaks. And it comes at an extreme financial cost. And if we see less patients, that's more in our emergency room. And so there's a dual crisis we're facing, which is whatever we've done to bring in additional staff and other things seems inadequate to the people that are actually doing the work, but they have real consequence on our finances, as we don't see as many patients or we bring in additional staff. And this is the balancing act that we're going through, and we're very fortunate to have you as a board that has a holistic perspective, and our missions and our commitment to the community remains the same. But it's one of those where you feel like as hard as you try, you're letting people down on both sides. And so I think we're navigating it as well as we can, but it's far from over. I think it's another 12 to 18 months of working through this.
I appreciate you talking about our broader workforce and who may be impacted, but I do think this also then gets at the question of who's able to navigate the healthcare system. And so within our systems, we know that there's a variety of experiences, but in the broader community, we know there's huge disproportionate rates of excess death amongst working age population. One could assume that we have similar patterns with respect to long COVID there. And sometimes those who are in fields that were viewed as essential were treated as disposable. And are they also under accessing the care they need? What are the long-term societal implications there, right? What are the long-term societal implications for those who we've lost in those early numbers of excess death? And what are their implications for their children? And whether or not their children can avail themselves of higher education, whether there's upward mobility in the same way, or whether there's been a new stunting of that because of COVID. Not something for us at this table necessarily, but to the extent that we're part of an academic institution that could engage in interdisciplinary research, it's something worthy of our consideration. I want to thank you for this presentation, and I want to move on to item H3. So H3 is an overview of the University of California Global Health Institute program. We'll take a second to reset, and when you're ready, please proceed at your pace, Dr. Mazziota.
Thank you. This next topic is the UC Global Health Institute. It works across the 10 UC campuses and equips students and faculty from across disciplines and cultures with the workforce skills to be global health leaders. UCGHI is helping make global health a career path for many and our state's leader in the field. for today's topic, Interim Associate Vice President of Academic Health Sciences for UC Health, Dr. Dina McCrae, will lead the discussion and introduce the team.
Thank you, Dr. Mazziota, and thank you very much to the Regents. It's an honor to be here today in front of the Health Services Committee and the university community to introduce the leaders of the University of California Global Health Institute. Although the Global Health Institute just joined UC Health last year, the Institute has been working across the 10 campuses and across disciplines since 2009 to grow a strong network of global health specialists, scholars, and community partners. At the beginning of this academic year, the Institute formally joined UC Health's Academic Health Sciences Unit to further advance this important work on a system-wide level. The Institute leverages the expertise and power across the system through education, advocacy, and research to drive the Institute's mission, which is to train the next generation of diverse global health leaders who will discover and implement transformative solutions to our global health problems. Dr. Madhavi Dandu is the director of the UC Global Health Institute, and today she'll be presenting the Institute's goals and accomplishments, which are in alignment with the UC Health and state initiatives of health equity and social justice. She'll also share how the Institute extends what it learns and implements in California to help others around the world achieve their own equitable access to education and healthcare. Dr. Dandu received her undergraduate degree, medical degree, from the University of Michigan, completed her residency training in internal medicine at UC San Francisco, and received a master's in public health at UC Berkeley with a focus on international health and human rights. And also joining us today are Dr. Ndola Prata, the Associate Director of UC Global Health Institute and a professor in the UC Berkeley School of Public Health, and Deputy Director Sun Cotter, who leads operations and strategic development. Dr. Dandu, could you please begin the presentation?
Perfect. Thank you so much. Thank you, Dr. McCrae, and thank you so much for having us here. It's really my pleasure and an honor to represent the work of UCGHI. We at UCGHI believe that everyone in California and beyond deserves an equal opportunity to be healthy and an equal opportunity to access high-quality health care. As an institute, we're trying to address the issues that are too complex to be solved by any individual, any discipline, or frankly, even a single university. As an organization, we have pioneered a new model that creates collaborations across the UC system and leverages the power of 10 using education, research, and advocacy to innovate structural solutions to the causes of poor health. We are the leading public university in the world, and UCGHI has really allowed us to put this university on the global health map. Our network is made up of local and global multidisciplinary collaborators who are working with students, faculty, postdocs, community partners, as well as many other folks like health providers and lawyers and policymakers to work on cutting-edge issues related to gender and health, planetary health, and many more. And while I'm here showing an image of California, I'd like to emphasize over the course of this presentation how we do our work locally and globally, and that the impact of our work happens at the state level as well as the international level. We've really been We've really been able to do our work because of early visionaries like our founder, Dr. Haile DeBoss, philanthropic investment, as well as the support of the campuses. We thank the chancellors in particular for their support, and for every dollar that you've invested, we've been able to garner over $20 in additional funding related to grants and fellowships. We know that the best solutions to the ills we face require a diverse intersectional workforce. We need to reimagine our institution to be deeply embedded in and connected to our communities. We also know that we must challenge existing power structures that have become barriers to health and ask ourselves hard questions about our role as a university in a health system.
we have to ask questions like, who are we including, or who are we excluding? Who are we serving? How are we helping? And frankly, sometimes how are we harming? Our goal is to do our work authentically as an institute, but also to self-reflect, to grow ourselves in a culturally humble manner. One of our special characteristics is that we've created an environment that fosters experimentation with novel solutions. I hope I'm not overstepping here to say that all of us have felt to our core the immense connection between the health of Californians and the health of the world, living through COVID-19, wildfires, floods. We have no doubt that the concerns in California reflect the concerns of the world, and the world's concerns impact us here in California. I'll spend the next few minutes describing our projects developing the workforce, doing research, and impacting policy. And in addition to our work in California, our projects have spanned the 77 countries highlighted here in blue. One of our proudest areas of work has been in the development of educational and training opportunities for those who are interested in global health. All of our programs are designed to reach diverse populations, support these same populations as they join the workforce, and ensure that the training provided achieves the university's vision of excellence. While embedded in the University of California, most of our programs have necessary and important involvement from international as well as local partners. And this workforce development pathway is designed to help create a diverse local and global workforce that looks like our communities. And we include learners all the way from the high school level to learners who are faculty and staff in our system already. Over a decade, we've reached more than 6,200 undergraduate learners, generated more than 600 in-depth student opportunities, and supported more than 20,000 fellows globally. These trainees have spanned all 10 UC campuses, Charles Drew University, as well as folks from 36 different countries. This slide here includes a selection of courses that we've developed over the last 7 years. We've focused on offering courses for undergraduates in particular, especially on campuses without global health opportunities. And these online courses have allowed students to learn content, of course, but also to be able to meet role models as well as mentors that they can continue to work with over the course of their careers. Our hope in the next few years is to consolidate these courses for global health opportunities for graduate students, as well as a certificate program potentially for international partners and community members who might be interested in joining the global health workforce. This work aligns very well with the state goal for digital inclusion. While the numbers I shared in the preceding slide show our reach in terms of breadth, UCGHI has also played a pivotal role in creating opportunities for depth. We know that a subset of learners interested in global health will want to go on to earn degrees or do formal fellowship training or actually have careers in global health. For example, we supported UC Santa Cruz in the development of their new bachelor's degree program in global and community health. And this is really already gaining momentum as a popular major. Just as of January of this year, more than 85 students have declared an interest in this major, and we really expect that number to rise because most students declare majors in the spring. And while degree programs are one way to allow for deeper training, one of our huge areas of success has been to create and implement a plethora of fellowship and short course programs that allow for mentored hands-on experiences. Each program that is on this slide and our other ones that aren't included here focuses on a different content area, but I think what they have in common is a diverse set of learners and trainees, mostly from our underserved communities. We know that training opportunities that are provided close to the time an individual embarks on their career increases the chances that they're going to, one, be successful in their work, and two, that they're going to be more likely to stay and work in the underserved communities they're training in. I know you've had an opportunity to hear about two of these programs previously. One was presented by Drs. Jana Mazet and Badrina Smith in October of 2020, and another by Dr. Sriram Shamasunder also in 2020. As an example, I'd just like to highlight two of our fellows from our GLOCAL Fellowship Program. The GLOCAL program is a 12-month mentored research program or fellowship for investigators who are interested in studying diseases that affect developing countries. We have U.S. doctoral students, professional students, postdoctoral fellows, as well as international postdoctoral fellows from low and middle income countries. Our first highlight is Dr. Ojeda. She holds an undergraduate degree in psychology and Spanish and obtained an MPH and a PhD in community health sciences from the School of Public Health here at UCLA. Her GLOCAL project focused on deportation of Mexican migrants from the U.S., And she really credits her training time with GloCal to help set up her current work, which is focused on health disparities with immigrant women and incarcerated individuals. And she spends a lot of her time working between San Diego and in Tijuana, Mexico. Our second highlight, who is Dr. Madadi, is a clinician scientist. He's focused on obstetric translational research, and he's faculty at the University of Nairobi in Kenya. He was a research fellow at UCSF and received training in both epidemiologic methods, as well as stem cell technology. He's going to be using next generation sequencing to analyze microbial communities to predict the diagnostic signatures of adverse pregnancy outcomes. And the data is likely going to lead to prediction tools that can be used in low resource settings for early interventions to prevent poor pregnancy outcomes. We're incredibly proud of our education and training programs, but I'd be remiss not to talk a little bit about our research. In addition to supporting these education programs, our faculty and staff have procured and initiated more than $5 million in research. Universities, as we know, are homes of research in our communities, and each UC campus is a world-class research institution in its own right. But I think what makes UCGHI unique is it necessarily breaks down silos within and between our campuses to allow for a true interdisciplinary collaboration. Our faculty have done research in many topics, ranging everything from farm worker health in the Central Valley, disparities in drinking water access in California, local and global campus violence prevention, among many others. I can't describe them all here, but I'd like to spend a moment just highlighting one of our projects. The California Home Abortion by Telehealth, or CHAT study, is a 3-year patient-centered study with over 6,000 patients enrolled from 22 states in the United States. The goal of this project is to assess the safety, effectiveness, and acceptability of medication abortions provided by telehealth. This $1.1 million project is housed in our Center for Gender Health and Justice and is PI'd by Dr. Ushma Upadhyay. And the preliminary findings suggest that telehealth for abortion is safe, effective, and acceptable, and could be a powerful tool in addressing the surges in demand for abortion in protected access states, especially since the recent Dobbs decision. I'd like to take a moment in this slide also to highlight Dr. Upadhyay herself, because her experience really shows the multiple ways in which our students, faculty, and staff can be involved with the Institute. She first learned about the Institute when she was a research assistant at UCSF. As she got more involved, later she was awarded a fellowship as a junior faculty member, which supported her work measuring reproductive autonomy. As her research expanded, so did her role in the center, and she is now the co-director of the Center for Gender Health and Justice and leads a lot of our work on research, policy, and advocacy on gender and health justice issues. She's also a very active member of our Black Lives Matter task force. Of course, doing a lot of research is valuable, but sharing it is one important aspect, and so here I highlight UC Global Health Day. It's a system-wide conference that showcases the outstanding research, training, and outreach that's happening across the UC system. And really, it's an opportunity for our students, faculty, staff, visiting scholars to gather to share their work. Our inaugural conference was actually hosted by then Chancellor and now President Drake at UC Irvine. And while conferences are very common in academia, I think what makes this this day unique and special is that it really changes who's at the table. The conference includes folks from our community, folks from, especially our trainees, who are really showcased and highlighted as our experts. It increases the opportunity for us to communicate with folks that we don't often work with in academia. With immense efforts to increase accessibility by minimizing cost to registrants and increasing digital access, we've been able to include more than 4,200 registrants from 67 countries since we started in 2010. So developing a workforce and doing research is most impactful when we are able to change policy, advocate for historically excluded communities, and provide access to our services to diverse populations. Our programs and projects always work to consider this question: how will what we do change the health system or improve the health of our communities? While I can't be exhaustive, I'd like to just describe one specific initiative. The UCGHI Student Advocacy Initiative included 40 student advocacy interns and 8 faculty mentors from all 10 of our UC campuses, and their goal was to make a measurable impact on U.S. domestic and global policy, influence California legislators, and really try to make an impact on our larger UC community. They were able to engage more than 4,000 additional students, faculty, and community members by involving them in 3 letter writing campaigns that addressed all of our California legislators. The student advocacy interns also held 20 in-person meetings with legislators and staff, published over 20 op-eds on health and advocacy topics, and really engaged the community, the broader community, both on their campuses and outside, in congressional meetings, trainings, and community-based events to make sure that they knew that their voices could be heard. So at the University of California, we're really lucky to have a robust, innovative 10-campus system, lots of creative and brilliant people. However, the concerns we face now require us to rethink our current systems, especially as they impact the health of our population. COVID-19, recent flooding, all of these things remind us that while everyone's impacted, and I know we've already talked about this today, that the most vulnerable amongst us is disproportionately impacted by every disease and disaster. We have the potential to innovate solutions for equity, justice, and improvement of health in our communities. I know that we have the will, but UCGHI, I think, provides a way for talented, committed people to act. We break down silos, leverage the interdisciplinary creativity of our people, and respectfully listen to the expectations of our communities. So I hope that we get an opportunity to talk today a little bit more about the Institute. Thank you.
Any questions? We want to thank you for the presentation and for the engagement. We think this is really meaningful, and we appreciate you giving us this update.
Brief comment. I'll make a 1-minute comment, just thinking back to the old days. First, appreciate very much having you here, Tom, the work from 15 years ago to help get this underway. It's great to see it still moving with such power. And I want to just acknowledge our friend and colleague, Haile Debas, who had this as a dream really in the 1970s and 80s. This concept was kind of at that time, I think, to go back to where he was from in Eritrea and start a clinic and do something for his home community that he'd left as he went on to pursue his further training before coming here to UCLA and then up to UC San Francisco. And then the world events and his own expanded view of the world said, gee, there was something more that he thought he could do than just maybe a local clinic in a local space back where he'd come from. And the concept of something to really impact global health was a dream that he began to have for years. And so with great support from the philanthropic community and many colleagues here at UC, we were able to see this dream turn into a reality, and it's great to see it up and running with its momentum all these years later. So I just wanted to mention Haile and really congratulate him on this great impact he's made for people around the world. So thank all of you for what you're doing.
Chair Perez, could I just, one question? Thank you, Madhavi, for that presentation. I think the last decade's been, in some ways, sort of a golden decade for global health, with tremendous funding from many foundations, the Gates probably in the lead. But my sense is we're at a real tipping point where, probably appropriately, those foundations are now looking at putting their money directly into the developing world rather than giving it to a US university to do work. You want to comment on that, and what are we going to do when the financial underpinnings of our global health work changes?
Thank you, Chancellor Hogwood, for that. We were, in fact, just talking about that this morning again. I'll give you 2 sides to the answer. One is I'm really excited for that because, frankly, as global health professionals and practitioners, our entire responsibility and goal is focused on equity, and for people to do their work with the resources they need directly is more efficient, more effective, and so fundamentally we align with those principles. I think what matters for us as an institute to think about is that this global health work, being both domestic and international, focused on disparities and equities at home, allows for a different kind of collaboration. So I think our focus and transition over this next 5 years to 10 years is going to be looking at who our partners really are domestically, who are doing this work, where the global health expertise that we've gained over the last decade will be effective and helpful, and really re-expanding thinking about who our funding sources could be. I think rather than defining ourselves as narrowly with foundations that were focused only on international sites, I think what we're really needing to do is realign our values with people who've been working on equity and disparities forever, and frankly, really, really working with community-based organizations and partners at home to help us in this conversation.
Thank you again. We will reset for the last item before our break, which is item H4, a discussion on UC Davis Health strategic overview.
So for today's topic, Vice Chancellor and CEO David Lebarsky and Chief Strategy Officer Ron Amodio are here to discuss the strategic plan.
Thank you. Ron. All right. First, just want to thank you for the opportunity to be here to discuss what we're doing and where we're going, and hopefully get input and questions. It's a relatively short presentation, so we can leave enough time for any elaborations that might be desired. When I first arrived at UC Davis, we didn't actually have a real strategic plan, and we didn't have a chief strategy officer, and we didn't have a strategy office. And so I just want to recognize Ron Amadeo for his amazing work in really putting together not only a functioning office, but a truly engaged process to develop this strategic plan that stretched across a large number of faculty, clinical stakeholders, and administrators to get us where we are. Our vision on the first slide, tomorrow's healthcare today. I think that's what every academic medical center is striving to do, to be on the cutting edge and to embrace and develop the next generation, the next innovation, and the next cure. And everything we do is actually driven by this vision of what we hope to be doing, tomorrow, next year, 10 years from now. Grounded in equity, provide unparalleled care across California, transforming lives and communities. Our teams research and develop trailblazing therapies and technologies, educate and prepare a future-ready workforce, and drive excellence into all we do. And everything we take on is meant to embrace that mission. And hopefully as we go along, I will provide, because these are just words, right? Anybody can write nice words. But hopefully, by the time we're done, you'll see that we're actually living our vision and pursuing doggedly our mission without compromise. Values that are not included in the words above and that are really important is kindness, trust, and inclusion. The other words that we obviously embrace are all in the vision and the mission. And our patient promise is simply that patients are going to be at the center of everything that we do. And that's the way, of course, every health system should be. But in the past, some academic medical centers have been physician-centric, facility-centric, but we really, really, really are working extremely hard to make sure that we're always patient-centric. And that's, again, where we think everybody should be. A little bit about UC Davis Health and what it deploys in order to achieve the vision and the mission. We are the second largest employer in Sacramento's region. We now have an 18,000 person headcount as of last week. That's a growth from about 13,000 when I first arrived at UC Davis almost 5 years ago. So a rather rapid increase in the number of employed individuals across our health system. We have rapidly embraced our anchor institution mission, or our AIM, for community health. We have a tremendous number of initiatives all around the region and in our local underserved communities that have been recognized by a large variety of external government officials, such as Javier Becerra, making a couple visits and holding a recent news conference with us for some of our activities in that regard. And we're currently about $4.3 billion in revenue total across the entities. The UC Davis School of Medicine continues to grow and be successful in pursuit of some of the things that it is doing. Point-in-time snapshot, we have about 770 medical students, 1,300 faculty, about 270 research principal investigators. We could use a bunch more FTEs because we think there's a lot of demand to join our faculty, just for what that's worth. We have about 900 plus active clinical trials and more than $400 million in annual grant funding, a couple $100 million in NIH funding, and we are each year consistently turning in the highest level of NIH funding in UC Davis's history. It's incremental, but we're latest Blue Ridge rankings, I believe, we're going to be number 32 in the U.S., which will be, I think, our highest ever. The medical center and our hospital and clinics serve a truly unique place in the Northern California ecosystem. We're a little bit closer to the University of Indiana and Iowa than we are perhaps to San Francisco and LA, where there's a lot of competitive TQ facilities and academic medical centers. We are the only academic medical center between the Pacific Ocean and Salt Lake City and San Francisco and Portland. And there are a lot of people who rely on us to provide a level of services and a breadth of services that they can't get anywhere else. We serve as the level 1 trauma center for 33 of California's 58 counties, and that naturally makes us an ally to so many small community hospitals around the region. While we have 30,000 inpatient admissions into our licensed beds, we have constantly grown the surge capacity of our organization, and we actually take care of 46,000 inpatients each year. And the difference between admissions and inpatients is a technical one. But we have grown our inpatient service footprint by almost 50% in the last 5 years. We have 25 outpatient clinics scattered around the community and the ring communities, 24 partner care locations across Northern California, and many more that we serve via a Partnership Healthcare Plan Alliance, providing pediatric subspecialty services via telehealth for 14 Northern California counties for every single Medicaid child that might need us. And we have about 1.5 million outpatient clinic visits per year. Now, when I arrived, we're about 865,000, so that's grown tremendously. And that doesn't count about 100,000 other visits, maybe more, that we do under contract for all psychiatric services, for Sac County Jail System, FQHCs where we lease our faculty, and those are not included in here, and there are tens and tens of thousands that go uncounted. The Betty Irene Moore School of Nursing, an amazing success story. It's only been in existence for 10 years. It is now number 23 in terms of ranking by U.S. News and World Report for a graduate school of nursing, and the 7th best PA school in the United States. Really has a focus primarily on education, and is just hitting its stride in terms of getting research funding for what is a unique caregiver institute that focuses not only on the patients, but the people who care for our patients, so at home. All right, next slide, please. And anybody can stop me at any point, ask any questions. I mean, I'm good. This is a map of the region and just shows the dots that are our own clinics, and the little, I don't actually know what that that marker is, but the other things that look like a little bat are where our partner institutions are that we have formal arrangements. Most of our formal arrangements revolve around 4 different types of services. Obviously, like I said, everybody's a partner when it comes to being a level 1 trauma center. But our comprehensive stroke center, which was started a few years ago, received the highest level of award and from the American Heart Association this year that you can get, has tremendous outcomes, and we are markedly expanding our telestroke support of area regional hospitals. And our cancer center, of course, NCI designated comprehensive cancer center, has a couple of formal joint venture cancer center partnerships with several different hospitals, and we are seeking to expand that because, as we'll talk about it, disparities in cancer outcomes are prevalent in rural areas, and we think we can do a lot more to aid patients in those rural areas in that regard. And then pediatrics. We actually just published a kind of a landmark paper about our pediatric ED support of rural community hospitals, where we were able to cut down the number of pediatric transfers by 50% by providing support and advice to the local ED physicians. So all those are part of this UC Davis Health footprint. Of course, not everything is perfect. You heard the discussion, very appropriate, I might add, from the regents about are we building enough. We have an insufficient inpatient capacity. We start every day. Even we have 648, I think, licensed beds, the number, whatever, 646. We start every day at about 670, 680, usually go up to about 750 during the middle of the day before things work themselves out. And part of that is because no matter how many beds we've opened, people still want to come into our organization to get the care that they can only receive from a UC institution. I mean, it's extremely rewarding to know that we are serving that purpose. And ever since I have arrived, I've said these same words, that we are here to complete and not compete with any other healthcare organization that shares our values and that wants to help patients, put patients at the center of everything that can be done, and to provide care for patients where they want it, how they want it, when they want it, and always closer to their own homes and communities. And that has resonated in our region, and it underpins a lot of our strategy, is that, we're not in it for a short-term win or to wrest the next commercial hernia from some other institution. We're here to provide services that no one else can. And we have lived that by upskilling a lot of our neighboring communities. We've upskilled NICUs in several different hospitals. We've upskilled emergency departments and stroke capabilities and ICU capabilities throughout COVID and during the triple-demic. We were constantly providing virtual support to our partners. We still have a lot we can do in terms of decreasing the length of stay. I think that's our major opportunity. And, we're working and there's always a reason, but whenever you have a clogged up hospital, things do not flow through smoothly. And since we're always operating at above 100% capacity, things don't flow through as smoothly as they should. But Ron, who has developed a process improvement and operational excellence group, is really trying to tear apart all of the rate limiting factors so that we can get down and effectively increase the number of patients we serve within our four walls, which are stressed. And we have a very aggressive care at home strategy. It employs remote patient monitoring as well as visits. We have partnerships with several different organizations, and we are really trying to drive and change the demand for our inpatient beds and the length of stay by this comprehensive at home strategy. And we'll be seeing that rolling out aggressively in the next year. Reducing health disparities is really central to actually the ethic at UC Davis. I didn't invent that at all. There was a Center for Reducing Healthcare Disparities headed by Sergio Gaxilo-Aregar, who is really a leader and champion in that area. And he's continued to expand his efforts. It's not just words. We've gotten grants to send vans out into migrant working communities throughout the Central Valley and to reach them with testing and information and vaccinations, and now test to treat with Paxlovid. That continues on. It's one of the things that Secretary Becerra noted us as doing, as well as setting up vaccination clinics in a variety of underserved communities throughout Sacramento, and also launching our own vaccination efforts for homeless people experiencing homelessness. We personally vaccinated more than 20% of the patients experiencing homelessness in Sacramento last year. Our Healthy Aging Clinic, we talk about disparities. We often don't think about the fact that the aged and their caregivers can't always get all the care that they need, and they're not. And we have a model clinic that we think we've put together that brings together 7 different subspecialties: gait analysis, physical therapy, and obviously a memory optimization portion as well, and a family caregiver institute from individuals from our School of Nursing to help those caring for those with dementia to really learn how to do it better and how to cope. because they often need as much help as their aging loved ones. We have been recognized as an age-friendly health system. Along with this clinic, we have a age-friendly designation for our emergency department, one of only 21 in the U.S. I might add, I share that with several of the other UCs. We are truly leaders in that regard. As an organization, not UC Davis, but UC, in terms of the way we structure our emergency departments to embrace the fact that the elderly experience it in a different way. And we are continuing created a new fellowship in geriatric medicine to address the fact there are often not enough people schooled in the care of the aged in order to provide them with the greatest degree of WellSpan. Decreasing margins, we all know about that. Labor costs way up, supply costs way up. That's not being followed by the same degree of raises from either the Medi-Cal, Medicare, or commercial insurers. So finding ways to be more efficient is really critical, and finding other sources of revenue that will support our mission is also critical. So just working at that, and again, there are a lot of examples of that. We're proud of some other things that we've managed to do in the context of caring for different groups of individuals. The Human Rights Campaign Foundation gave us one of the few 100% scores in the United States for LGBTQ plus care, not only for patients, but how we treated our own employees in that regard and the support that we gave. And again, an example of that is we support the only transgender clinic in 3 counties in Sacramento, and provide administrative and personnel support. We are undergoing, in order to deal with our insufficient inpatient capacity and the progression of care down the acuity continuum. So as I think you all know, you've approved a very large and expensive tower that we're building that is really focused on very complex high-tech operations and a large number of ICU beds. And we're not building a ton more beds, we are building a ton more capacity, and via our 48X complex, which is one of the largest, or the largest ambulatory surgery complex in the US, and it will help unload all of those things in the one-night, overnight admissions that we think are really going to be prevalent in the next few years. So we're really trying to build a facility basis for the healthcare system of the future. Next slide. Maybe the next slide. We're thinking about it. Oh, now we've got 5 slides. All right, thank you. Oh, one back, education. One back, it's that one. There we go. Okay, is that right? Yeah, okay. So the education enterprise, has really been a high point, if you will, in the School of Medicine, the School of Nursing, the work that they're doing in terms of creating a workforce that is not only excellent, but truly reflects the communities in which we practice. As I think I noted previously at one of these meetings, we are the top School of Medicine for graduating Hispanic students in the United States of America. We are one of the top, if not the top, school for our students staying and practicing in the area. So we're not only graduating people who look like our communities, we are actually keeping them, and they're actually staying and practicing. And 74% of our 2022 medical school class will actually take jobs caring for the underserved. And our diversity within our School of Medicine class is the best in on the West Coast of the United States, and number 3 nationally. It's not only diversity in terms of ethnic makeup, but it is 67% are socioeconomically disadvantaged, and among the lowest, we have some of the least affluent classes in the United States. So we're not only turning out people who reflect their communities, but reflect their experiences growing up, unfortunately, without a lot of resources, which hopefully will lead to a more empathic and better health outcome for those that they continue to serve. Our research enterprise is just been doing extremely well. Again, each and every single year, we have markedly increased our research dollars and the impact that we're having. And I'd like to talk a little bit about, the future. Because what do these numbers really mean? We continue to invest in a lot of team science, a lot of seed grants. We just recently launched with the main campus. We have a tremendous amount of cross causeway, if you will, research collaborations. An Institute for Psychedelics and Neurotherapeutics. There are several others already in existence in UC, but we actually, with our broad base of veterinary, agricultural, and biological science expertise, actually, I think are going to bring some unique looks at this. And we've already had great successes. There's an individual actually on our main campus who's a leader of this institute that we've founded that's invented the first non-psychedelic psychedelic, meaning that it's stripped the trip from the medicine, but kept the neuroplasticity and neuronal growth characteristics of psychedelics. So that's going to be very exciting as we pursue this. And we think, when we talk about, the next innovation, the next cure, we really believe that psychedelics are going to be a big area, and it is getting a lot of our investigator-initiated focus. And we're about to launch a microbiome institute as well in combination with the main campus because, again, it's another organism that lives within us in our gut, and we don't fully understand their impacts on the disease process. Okay, I think that does it for the actual presentation. I left open a lot of time for any questions that you have about where we're going, what we're doing. I can tell you why we're doing it, which is because we all really believe...
I will reclaim the time then. Let's go. Regent Riley.
Okay.
Thank you so much. It's so exciting to always hear what's happening at Davis. I can't find it as I'm looking back in this presentation, but I read, I believe, that 66% of your medical students are going into primary care. Is that true?
74%, yes.
74%.
Yeah,
wow.
we
That's
ranked
amazing.
number 9th in the U.S. for primary care education by U.S. News and World Report.
And what is there? There's such a, we're losing so many primary care docs and so many, obviously, new doctors want to go into specialty care. What's the secret of that success?
The faculty, they really believe in this, in what they're doing, and they relay that to the students in a way that only genuine authenticity can, and they do, and they lead by example, and we also. It took a little, it was a very large discussion about what our role was, right? Should we just be taking the students with the highest MCATs, or should we be taking the students that would have the greatest impact on their communities? And that debate was raging when I arrived at UC Davis. And there were reasons for both, but we settled on the fact that our purpose, right, was to make our communities healthier, right? And that the theoretical benefit of having someone with a high MCAT score wasn't actually the end point. And that allowed us to open up our doors to people who are excellent physicians and are really going to serve their communities. And we have a lot of different programs that are going to put people back in their communities, meaning people from the Central Valley, people from the Sacramento Urban Core, the new PRIME program for Native Americans. These all really make a difference in terms of getting care where care doesn't exist. And so, and our students believe in all of this. They make me and Ron better leaders, because if we don't do it, right, believe me, they'll let us know we're not doing the right thing.
Thank you.
Regent Park.
Thank you. And Vice Chancellor Lubarsky, thank you very much for the presentation. Certainly there are a lot of moving parts to running a health system, and an academic one at that. So my question really was, in terms of sort of all of the strategic priorities and then the goals for the three different, branches, let's say, I guess what I was wondering about was how will you know that you are succeeding? And it's really about kind of metrics you're defining for yourself, and some of them are really hard to define. And certainly, giving them all to us, it's, again, a lot of moving parts, a lot of different goals, et cetera. But can you give us your, what are some maybe specific goals, specific metrics you're using to indicate, yes, we're getting to where you think the system should be?
Right, so every single one of the principles and goals that we have actually does have a metric associated with it. Ron, do you want to talk about our enterprise-wide balanced scorecard? We didn't include it, I'm sorry, just a lot of numbers and data, but we're happy to share that with you anytime.
Okay, hello. Yeah, so this is the balanced scorecard. It's a brand new tool for us. It's got 48 metrics, I believe, that are attached to our strategic plan. They kind of cross service and finance and other areas, people. And so we have also built an enterprise project management team that is actively managing every project towards every metric. We report out on those quarterly. We also post them on our intranet so that the folks who are involved can keep pace and they know if they're falling behind. And these metrics have champions that go all the way down to the clinic level.
Right, and just to be really clear about that, when we say we want to, get to equity, we have very specific goals, right? And, one of the ones that has come up in this discussion, for example, was trying to make sure that, if you want real equitable health outcomes, you've got to have, economic opportunity and educational opportunity, and then healthcare access and treatment together. And, we have really set ourselves out to employ more and more people from those zip codes in our local Sacramento area that have the highest levels of unemployment and the lowest levels of median income. And we have increased the employment from those zip codes from about 8% to 19% of our non-licensed workforce. And we're going to continue to do that. And we've set those goals for ourselves, right? They're internal goals, right, to continually make sure, and when we talk about equity, what does our community look like? What does our workforce look like? What do our managers look like? What do our supervisors look like? And what do we need to do to make sure that our organization fully reflects our community and provides a career pathway while we are taking great care of patients? And, and I get this question a lot. From people perhaps who are not fully schooled, not in this room, but from other colleagues from around the nation, like, well, you're doing all this, aren't you giving up on excellence? And the answer is, of course not, because excellence is part of our balanced scorecard. And, we're an outlier for trauma outcomes for CMS because they're so good. We're an outlier for our comprehensive stroke center because our outcomes are that good. We're an outlier for the number of people we're sending back to underserved communities, because that's what we're about, and we're not compromising anything in order to achieve that equity. We're actually just we're elevating the entire level of the discussion, I think, around what a healthcare system can look like.
Can you elaborate just on a couple of things, staying on the subject of metrics and staying on the subject of equity? And you had talked about eliminating health disparities before. What are some of your metrics for eliminating health disparities for the community? And as well, what maybe can you also talk about your metrics on telehealth?
Okay, so so in order to eliminate healthcare disparities, right, you have to make sure first and foremost the people. We've given everybody insurance, we haven't given everybody access. So we've attacked this from several different angles. Number one is for our own clinics, we measure whether or not people with different insurance characteristics can have the same time to appointment. And I can tell you 100% that virtually every single, because we follow every single clinic, there's no gaming of the system. Everybody gets equal access to our physicians. And we've also taken, in our funds flow model, we've taken away any benefit from seeing commercially insured patients versus Medi-Cal patients that are at the ground level. There's no benefit to queue people differently. But that isn't enough, right? Because a lot of times there's just not enough people at all in our system, you're treated equally, but not in the community. So as you may have heard, we just announced we had to get a HRSA waiver to do this, but we announced what we think is a new sort of model for how academic medical centers can partner with FQHCs, and we've created a hub with WellSpace, which is our largest FQHC in Sacramento, to create a subspecialty hub, totally staffed by UC Davis Health subspecialty physicians. They can't hire them because it's pretty basic level subspecialty work. So by rotating in UC Davis faculty, we can continue to hire the very best people who then serve Medi-Cal patients in these underserved areas directly, and they will accept patients from all over. That is not just WellSpace's 26 FQHCs, but from any of the 40 or so FQHCs in town, and then send them back, or send them on to us for advanced subspecialty work with a warm handoff. This is a new model, and it works because it's not charity. Because FQHCs have full wraparound services and full cost reimbursement supported by the federal government, they can actually subcontract with us to hire our physicians. They wouldn't be able to get that level of quality without us, so it's a really good partnership. And we're starting with rheumatology because Sacramento has had a shortage of the ability, but we're hope to have about 8 or 9 subspecialties present. We already have that model in partnership with Sacramento County, and that's the biggest issue right now with the Medi-Cal population here, especially in Northern California, is people have insurance and people supposedly have access to subspecialists, but if you call up, you cannot get an appointment if you have Medi-Cal, and we're seeking directly to change those access metrics with our partners, and that will help. It won't guarantee, but it will help on the first step towards equitable health outcomes. Then we have to start doing even more, and we have an oversight board that we're part of for the managed care Medi-Cal companies about them using the CalAIM waiver to provide additional non-medical services so we can begin to attack the social influencers of health while also providing timely subspecialty access care.
And I asked about telehealth.
Oh. Okay, so there's a ton going on with telehealth, right? So we have about, like I said, we have a very large telestroke program where we help EDs diagnose and treat and or transfer acute stroke victims. We have a very aggressive telepediatric presence across many of the rural community EDs. And as I mentioned, we have a e-consult service for all 14 Northern California counties through partnership healthcare plans. We've continued to have our regular virtual health visits for our own physicians and our own patients, which still amount to about 16%, about 15-16% of total visits any one day are still being provided via a virtual format. And we consider that to be an equity play as well, because if you don't have to take off a whole day, right, to go travel to the doctor, sit in the office, get seen, right, or if you're a caregiver, take off from work to take your loved one to a physician, but can handle that via virtual health. We consider that be very positive in terms of equity, and we have a digital health equity program as well, funded by the federal government via a earmark from Doris Matsui, which is providing care navigators in a virtual format with a large number of non-English speaking care navigators to help those individuals.
One more question, Mr. Chair?
Please, and then we have to move on to the last question.
Okay. Just one follow-up question was, I didn't hear much discussion about, though, information systems and the administrative work that our healthcare system still needs to work through. And I was surprised, by how many times, somebody needs to make a copy of your insurance card. And I'm just wondering what your perspective is as you're advancing your strategy on the investment into streamlining administrative barriers, as well as investment into information systems.
Right. So we have a full digital Davis strategy that is in parallel to this and is it's a main supporting feature of all of the rest of the strategy. And becoming patient-centric is about getting rid of redundant and low-value interactions such as you filling out paper forms and copying your insurance cards 22 times and being asked the same questions over and over again. And yeah, we have work to do.
We have an AI strategy to try to get rid of some of the redundancies that are happening out there, but what you're touching on has a lot to do with regulations and things that we actually have to do. If we can get more of our patients to opt into digital deliveries, we might be able to back ourselves out of some of the problems that you're describing.
But they're very real, and they're a total waste of time, and they're definitely worth working on. As Ron said, sometimes we have to ask the same questions, and we have to get the same information, and it shouldn't be that way, but it is.
Thank you.
Thank you. Regent Batzer.
Thank you for your presentation and the impressive work that you're doing. Reducing health disparities is a goal that we share. And I note that many of our Black and Brown communities are covered by the Medicaid program, called Medi-Cal in California. And nearly 40% of the California population is covered by Medi-Cal. Do we know the percentage of UC patients that are covered by Medi-Cal? Because it seems that if we want to address disparities, we could start by making UC services available to these populations. And I'm new to the board, but I think as a board, we ought to be tracking that percentage, and we ought to do at least as well as the percentage of the California population that's enrolled in that program. Thanks.
Sure. 41% of our inpatients are from the Medi-Cal program, and which is, along with San Diego, some of the highest percentages of any non-state or county-supported, I know we're a state organization, not really state-supported, though, healthcare system around the United States. So I think that we are definitely doing our part there. In our own clinics, I believe the latest number was about 22% of patients are Medi-Cal, but that does not include about 10% of our patient visits that are provided under direct contract to people in prison, in FQHCs with Sac County, and where it's our physicians who are doing this, it's our administrative work, and where our FQHCs have actually asked us not to provide a large amount of primary care outside of their walls, because then they won't meet their volume characteristics necessary to maintain it as an FQHC, which is why we focused on trying to change access for the subspecialty group in that regard.
One other observation is I know that we all love FQHCs and admire the work they do, but most low-income communities aren't primarily served by FQHCs. So I think we need to expand our thinking about who the providers are in the community that are taking care of our low-income ethnic populations. So just wanted to share that.
No, it's definitely an issue. As I've said, everybody has insurance, but access is an entirely different story. And understanding the geographic distribution of clinics that will see those patients and understanding where there's a gap and a need was part of our community health needs assessment this past year that we do in combination with the other health systems, Kaiser, Sutter, Dignity in our region. And we've identified some areas where either we need to open or support additional expansion in areas that are not well served. So it's a very good point, Regent.
Thank you.
Thank you. That concludes this item. With this, we stand adjourned for open session. We will be reconvening in closed session at 1:10.